Okay, good morning, everyone, and thank you all for joining us today. My name is Danielle Davis, and I'm going to be coordinating things on the back end of the event. If you have any questions during the presentation, then feel free to place them at the bottom down in the Q&A box, and Dr. Barmada will get to those questions during the presentation as well as at the end. Um, and Dr. Barmata, if you can go to the next slide for me. Thank you. Okay, so just so everyone knows, we are recording this event and it will be available later this week on our YouTube channel. So if you can share this information or if you want to go back and review it, then you're more than welcome to do so. Also, there will be an evaluation that will be prompted once the event is over, as well as it'll come in an email. So if you can please take the time to fill out the event evaluation, your feedback is greatly welcomed and appreciated. So next, it gives me great pleasure to introduce our speaker for today, Dr. Sami Barmata, who is an associate professor of neurology at the University of Michigan. Dr. Barmata received his MD and PhD from Washington University School of Medicine in St. Louis, Missouri. He was awarded the Young Physician Scientist Award from the American Society for Clinical Investigation in 2014, and he received the Distinguished Angela Dobson and Lyndon Welch Research Professorship at the University of Michigan in 2015. So, if you all will please um, welcome me as we hear from Dr. Barmata today.
Right. Thank you, Danielle. And I want to say it's a pleasure to be here. I would also like to say it's great to see everybody, but I don't see everybody. But even so, I want to reiterate a lot of what Danielle said. I'd like to keep this as interactive as possible. So if there are questions or if something isn't clear and you want to stop me, feel free to do that. Otherwise, you could always answer questions at the end too. So as Danielle mentioned, I'm a neurologist practicing at the Alzheimer's Disease Center and the Cognitive Clinic at the University of Michigan. But I also spend, actually I spend the majority of my time in the laboratory researching these diseases, and in particular, some of these other conditions that fall under the sort of larger umbrella of dementia, um, including frontotemporal dementia and some related conditions. So today I'm going to be talking about what dementia can be if it's not Alzheimer's disease. And the other way to think about this is that it's really not always Alzheimer's disease. And I think that this is a common sort of misconception or a common assumption that I think we find very often in the clinic. And that is to really just have this impression that all dementia is Alzheimer's disease. And actually, I like to think in terms of analogies, and I call this the Kleenex analogy, right? Because we always call facial tissues Kleenex, and any sort of facial tissue we refer to as a Kleenex. But as a matter of fact, there are different brands of facial tissues, and some are more common than others. But Kleenex is the most common brand, and it's the same way with Alzheimer's disease. So Alzheimer's is not the only type of dementia, but it is probably one of the most common, definitely so in people as we age. So if you get over the age of around 60, 65, Alzheimer's becomes the most common reason to develop memory problems. But there are several others, and I'll talk about each of these in a little bit more detail over the course of this talk. So close running, close second to Alzheimer's disease, not really close actually, but similarly, not quite as common, but we see it very often is vascular dementia, and that's because it's never pure. So vascular dementia refers to problems with blood vessels, kind of the same problems that you would see in heart disease, except instead of affecting your heart, it affects your brain. And it's almost never in isolation, so it bleeds through and affects many other conditions, including Alzheimer's. We see a condition called Lewy body disease not infrequently, and Lewy body is one of those things that you may not find unless you know what you're looking for. And so very often, I think it is not recognized or even misdiagnosed unless the physician or practitioner or even family member knows what they're looking for. And then frontotemporal dementia, even more so. So this is another type of condition that affects memory and many other things that your brain does. And it just doesn't look like what we typically consider to be a dementia. And so very often it is not even considered. And then there's something called Parkinson's dementia, which in fact is very closely related to Lewy body disease. And so I'll try to do over the course of this talk is to consider each of these in turn. We'll spend a little bit of time talking about Alzheimer's disease only to sort of emphasize how distinct or different each of these conditions are from Alzheimer's. All right, and then there's, sorry, this last category, which is other, and hopefully at the end we'll talk about that a little bit too. So Alzheimer's, and just very briefly to go through some of the basic characteristics of Alzheimer's, it's insidious onset, meaning it starts something very, not very extreme at all, not very significant, but can progress over time to become something that you cannot ignore anymore. And the most common feature that I think we're all sort of aware of and really comes to the front is short-term memory loss, meaning if you tell somebody something, they will have no memory of ever hearing that from you, or if they watch something or hear something or read something, they will not be able to recall it. That, even though that's the most common sign of Alzheimer's, that's not everything. So many people with Alzheimer's may have changes in their behavior. They may suddenly become somewhat aggressive, or they may become, if they were aggressive before, they may become passive. Sometimes people have language problems, particularly word finding problems. And then there's this very unusual condition that we see sometimes with Alzheimer's, where people are not able to recognize objects that are in front of them. So their eyes work, the pathways that go from your eyes back to your brain works, but your brain cannot put together those details, this shape, this black thing, and say that this is a phone. And that is something that we encounter with Alzheimer's disease. And importantly, there's no other good reason to explain it. And that's definitely something that we look for every time we see somebody. So under the microscope in the brain, what you see is this. And this is a picture of somebody's brain, that somebody who had Alzheimer's disease. And we can see the accumulation of two very distinct proteins, the brown stuff and the black stuff. And the brown stuff are called plaques, and these are chock full of a protein called amyloid that you may hear about. And then the black stuff are things called tangles, and they're full of a protein called tau. And this is exactly what we use now when we try to diagnose Alzheimer's. We don't actually need to wait until somebody has passed away. Now there are techniques, imaging techniques, even some blood tests that can detect these proteins when they build up in people now. And that has changed a lot only within the past few years. So what do we do when we do see somebody with Alzheimer's? What are the treatment options? And I put this in here, again, just to contrast it with what else we're going to see. So there are two medications that are approved by the Food and Drug Administration, the FDA, and covered under insurance, and that's Aricept and Namenda. These may modify different amounts of neurotransmitters that your brain uses to communicate among the different cells of your brain, and they help. But it's not a huge effect. Most of the time, I tell people that what they do is they help slow things down, so they don't actually improve your memory, but they keep it from getting worse as quickly as it would otherwise. And really emphasizes the sort of gap and the need for something better. Just as effective as the drugs, though, are the things that are non-drug related, right? So what else can we do to improve our memory? These are things like regular physical activity, mentally engaging activity, so something that stimulates your brain. I like to think of the phrase use it or lose it. So you got to keep doing these activities, things that make your brain work a little bit, and that keeps it alive. Sleep is incredibly important, regular, high quality sleep. And then education is actually, it turns out that the more the education, the lower the risk of developing a cognitive problem or dementia as we age. And we still don't understand how all these things interact. I want to throw this slide in there. It's a really crazy slide, but this is just a sort of visual representation of all the different therapies that are now being tested in people with Alzheimer's disease, right? So there's over 120 different treatments that are in some phase of testing, right? So it's a very active area, and this is why I say it's changing very rapidly. And if we look at the center of this crazy diagram, these are the things that are in what we call phase 3 trials. So the last phase of testing where we're actually looking at their effects in people with Alzheimer's disease. And probably heard about some of these things in the news in terms of Biogen, and I personally hope that we hear much more about these things in the news in the coming months to years. Okay, so let's talk about some people. So these are real people. Of course, their names have been changed, but Carl, he is almost 80 years old. And when he comes in the clinic, he says, I'm fine. I don't feel too bad. But his son has a different take on things. And he says that, he had a heart attack. Carl, his dad, had a heart attack about last year sometime. And he's just not the same. He's not remembering things the way he used to. And he's a little slower. And so this is sort of reference to what we see with vascular dementia, right? I mentioned that this is very closely related to heart disease. And that's because your heart is supplied by very tiny, tiny little blood vessels or pipes that bring the blood to the heart. And we see the same tiny, tiny blood vessels in the brain. And those are the ones that are hit by the same problems that we see in heart disease, like cholesterol and high blood pressure. It's very common and affects between 10 to 40% of people with dementia. And there's a lot of overlap into these other conditions, right? So it's not black or white, Alzheimer's or vascular. It's very commonly both. There you go. And typically, we think of a blockage in the blood vessel to the brain causing a stroke. And so it definitely can, especially when you get the big highways of blood that go to your brain, the big, large arteries, that causes what we clinically recognize as a stroke. But it doesn't have to be those big events. It can actually be very small, subtle things that you or me would not notice because your brain is so good at repairing itself. But over time, they can accumulate and cause damage in a cumulative fashion, meaning it just builds up over time. And one of the primary things you see with this is this really vague description of executive dysfunction. And what this means is it can mean any number of things, but executive functioning is what I think of as higher cognitive function. So calculations, how quickly you do a task, multitasking, prioritizing, planning, lots of different things fall into how well you use tools or follow directions. These are complicated tasks that require attention. And this is the category that we see most often affected. And this is how we diagnose it. So we often use history, right, to look at whether or not there are these risk factors that we link with heart disease, but also brain imaging, in this case, an MRI. And we look for these areas of white that appear white on the MRI. And those are areas that have not gotten enough blood. And because of the sort of changes on the MRI, we can see that as very distinct. And, in a more gradual onset, that is sort of patchy dot-like areas everywhere in the brain. And this is what happens when you hit an artery, with a big stroke, and one particular part of the brain that's supplied by that artery is affected, and it's kind of like a wedge that's affected. So these pictures help us sort push us towards that diagnosis of vascular dementia. All right, so I mentioned these risk factors before, but there's a lot of things, right? If you're a guy, I'm sorry, but you have a higher risk of developing vascular dementia as we age. Of course, high blood pressure, diabetes, cholesterol, cigarette smoking, these are all the same things that, often you go to your doctor and, your primary care doctor and try to look out for, because they're common as we get older, and they do increase your risk of developing heart problems and brain problems. So what do we do? Well, we try to treat those risk factors. We want to lower the blood pressure, lower the cholesterol if we can, make sure your blood sugar isn't out of control. Even though it's sort of down here close to the bottom, exercise and diet is, like I mentioned before, probably should be near the top, because we know that regular physical activity makes a big impact on heart disease, likewise with memory and in particular with vascular dementia. Sometimes you can, if there's a blockage in some of the big pipes that go to your brain, the carotid arteries, you can have a surgery to remove that. It's a particularly in a high volume center. It's a very safe surgery. And then sleep, definitely sleep. Right. So that is vascular dementia, and that is something that we see very often, and you may definitely come in contact with when you talk to your primary care physician, or if you ever see us in the clinic. It's always something we think about. All right, so we're going to switch gears now and talk about another person. This is Charles, also in his 70s, and very unusual history. So he was having a lot of problems at work. He's an accountant. Before, he was still doing a lot of the finances when he got home, but when he retired, but he was having a hard time with them. And sometimes he would even pass out, particularly when he tried to stand very quickly. He was seeing things that his wife weren't seeing, including kids out in the yard. Not really bothered by them, but still pretty unusual. He had some sort of aggressive episodes of aggressive behavior, mainly at night, a lot of kicking and punching. Although he's always had problems sleeping, and his wife noticed that one of his hands was shaking. So many of you have maybe put this together, but this is sort of a combination of a couple of different things. So he looks like in some ways that he could have some Parkinson's, right? Because he's got a little bit of a tremor. Very often people with Parkinson's may pass out or have problems walking. And then there's the problems he's having with doing his work. So this is a reference to Lewy body disease, and we'll get into the exact symptoms. But really, there's this sort of back and forth between Lewy body dementia and Parkinson's disease with dementia. And I'm a lumper, and these two conditions are actually caused by the same problem, right? It's under the microscope, as we'll see, it's the same thing that causes both diseases. It's just if that disease starts with memory problems, we call it Lewy body. If it starts with things that look like Parkinson's, we call it Parkinson's disease with dementia. And that distinction is actually a little bit arbitrary. So this is, and as a matter of fact, they can be treated very similar to one another. So this is not uncommon. It's hard to say exactly how common it is because it really depends on who's recognizing and who's giving it a name. It's probably about a fifth of all people or more with dementia. And under the microscope, when you look in the brains of these individuals, they have what we call Lewy bodies, which really is why we call it Lewy body disease or Lewy body dementia. And this is what a Lewy body is. It's that bright pink circular thing in this brain cell. And why do we call it a Lewy body? There was a pathologist decades ago whose name was Lewy. His last name was Lewy, and he was the one who first characterized this, and so we call it a Lewy body. And it's very unusual. So very often it's hard to really call this, it doesn't, again, fall under what we classify as dementia, right? Because memory problems are not always the first thing. Very often it's this inability to really pay attention to what's around them and actually know where they are in space, right? For instance, right now in my house, I'm working from home. In my house, I know that the kitchen is right beneath me and my lawn is out that way. But this is one of the things that we lose very often in Lewy body disease, your sort of representation of where you are in space. This executive dysfunctioning, so doing tasks. And there are some other unusual things. So the visual hallucinations, I mentioned seeing the children out in the yard, very common. Problems in sleep, very common, which we'll talk about. These things that look like Parkinsonism, so things that look like Parkinson's, which is why I call it Parkinsonism. Problems walking, sometimes shaking, sometimes people look really stiff. And then there's this fluctuation. So people have a really good day and then they have a horrible day. And they may be incredibly sensitive to certain types of medication too. And I want to talk a little bit about the hallucinations because it's one of the most characteristic things about Lewy body that can help us identify it and guide treatment. So when I think hallucinations, maybe this is more relevant to the time in which I grew up, but I think of these sort of wacko, multicolored things like somebody is tripping on acid, right? Again, I think that's because of when I grew up. But in Lewy body, this is not the type of hallucination that you see. It's most often animals or people, friends, family that have passed away. I had somebody that I was seeing who saw a band, and actually they really liked the music and they enjoyed it. So they're non-threatening. They're often not scary to people, unlike many other types of hallucinations, and that's an important distinction. And it helps, again, push us towards Lewy body disease. I also want to talk about the sleep problems because there's a very unique sleep problem associated with Lewy body dementia called REM, sleep behavior disorder. And many people have heard of REM sleep or rapid eye movement sleep. This is the part of sleep where you're in very deep sleep and it's active dreaming, and the rest of your brain, the rest of your body is paralyzed, except your eyes. And what happens in REM sleep behavior disorder is that that function of paralyzing the rest of your body, it doesn't work anymore. It doesn't work quite as well. And so you actually start doing the stuff that you're doing in your dreams. And it can be, as we can see, it can be really bad. I see there are a couple questions here, and I'm going to answer those in a second. But this is what REM sleep behavior disorder can look like. So this man is quietly sleeping in his bed, but then, I don't know what he's dreaming of, but maybe he found a spider next to him. And so he just, in any case, this can be very disturbing for the person when they wake up someplace or their partner in bed. And very often this shows up 5 to 10 years even before any of the memory problems. Okay, so I'm just gonna switch gears a little bit. I saw a couple questions pop up. So there's one question about losartan, which is a medication for blood pressure. Will it also help for memory? It's not going to improve your memory per se, but it can reduce the risk of things getting worse, right? That's what we want. And in that case, if we treat the blood pressure and it lowers, I think you're going to be at lower risk for the memory problems getting worse. And then if a person invents a memory and tells a story from his past, which we know is not true, is that considered hallucination? No, that's actually a little bit different. That's what we call confabulation, which is a sort of fancy word for making it up. And it's technically different from a hallucination because it's kind of like a false memory. And there are, it's interesting, there are some conditions, even some parts of the brain that we can associate with that. Sometimes it's due to a vitamin deficiency. And so it's worth looking into a little bit more. And I think this question, is that characteristic of a specific type of dementia? I'm guessing the REM sleep behavior disorder. And yes, very often we see it in Lewy body dementia and Parkinson's disease with dementia, right? These conditions with Lewy bodies. is the brain mechanism for hallucination similar or related to the mechanism underlying REM sleep behavior problem? It very likely is. And this is one area in which we need a little bit more research, and it's hard to research actually. But the Lewy bodies that develop in this part of the brain called the reticular activating system is the part that does the Lewy body disease, we think. And that's when we see that problem in that part of the brain, we also see hallucinations. So there's something about the connections between the cells in that area that can actually do both. All right, and yes, confabulation is kind of making up or believing in something that is very different than reality. All right, so additional things that we see in Lewy body dementia. So the falling part, that is also very common. Many people have experienced this. If you stand up quickly, that you may feel a little lightheaded. So your body needs to respond by increasing blood pressure to push the blood up to your brain. And what happens in Lewy body disease and several other conditions is that that response is lacking. And that's something that is carried out by this part of your nervous system that just functions in the background. So we call it the autonomic nervous system, and it just doesn't work as well in Lewy body. And I mentioned the sensitivity to drugs. So it's harder, MRI can often not really that helpful in Lewy body. Sometimes it's better off in telling you what's not there, like vascular disease. It can show some shrinkage or atrophy in particular parts of the brain, but more useful is something called a PET scan, which we'll talk about in a little bit. And even more useful than that are a sleep study, right? Maybe you can pick up REM sleep behavior disorder or something else. And there are these very rarely used tests that can often be used very effectively if we want to diagnose Lewy body. So one of them is something called a Dat Scan, which is a dopamine transporter scan. And dopamine is a neurotransmitter in your brain that whose production is really pretty deficient in Parkinson's and Lewy body. And that's something you can see here. We're looking for that bright pink signal that indicates dopamine transporters, and it's just lower in people with Lewy body. All right, so I'm going to get to the questions as soon as I finish the Lewy body part. The next one is something called Mibg Centigraphy. And I will say that in the United States, we rarely, if ever, use this. But in Europe, it's used a little bit more commonly. It's kind of like a heart scan where they give you a labeled sort of solution through the IV, and they look for, it actually labels nerve endings near your heart. And so you can see this dark area in the person with Alzheimer's that is absent in the person with Lewy body disease. And the last one, which I think is the most approachable, is to get a sleep study. And the key here is just like REM sleep behavior disorder, they're looking for movements during sleep, right? And so you end up, anybody who's had a sleep study, it can be a lot of fun. You end up going to sleep in this place with all these wires on your head. But you also have wires on some of the muscles in your body. And so if you keep your, look at this red trace kind of in the middle, what they're seeing is that your muscles are twitching, right? Even if you're not smacking the bed right next to you or getting up, your muscles are twitching. And that, again, says that that part of your brain that should be paralyzing you isn't. And this is REM sleep without atonia, and that can be an indicator of Lewy body disease. All right, so there are a few genes associated with Lewy body. We don't have to get into the details. They're actually very rare. So what do we do? Well, so if there are cognitive symptoms in Lewy body disease, there's actually a class of drugs that seems to help a little bit. It's hard to really put a finger on how they help. Most often in people who take them, family members or person with Lewy body will say, I don't know, I just, I feel better. And their family members will say, they're kind of more like they were before. And that's because it probably affects this domain that we call executive functioning, right? A lot of different things. These are the same drugs, Aricept is like the flagship drug for Alzheimer's, right? But it turns out it actually has a bigger impact in Lewy body than it does in Alzheimer's. And what about these hallucinations? So it turns out a little bit of Aricept or some of these other drugs in the same class, they can make the hallucinations substantially better. Now, it's important to remember that, just because somebody has hallucinations doesn't mean you have to treat them, right? If they're not really bothersome, if they're not getting in the way, most people recognize the fact that they're, not real. I often don't recommend any treatment for that. Just depends on if they get in the way. All right, and so there are other medications. So if hallucinations are very disturbing, then there are stronger medications, including antipsychotics, that sometimes we do recommend. Very rarely. If we can avoid them, we try to avoid them. For that REM sleep behavior disorder, melatonin, over the counter can be really, really effective. But it's important that you use the melatonin correctly. And that means staying away from light sources like fluorescent lamps, the sun, your iPhone, and the TV or your computer screen. They'll all break down the melatonin. So it pretty much makes it worthless if you take it and you look at screens. Klonopin is another one, but again, we try to stay away from that. If there's autonomic dysfunction, using compression hose can be actually really helpful and prevent a lot of people from fainting. Sometimes we really need to increase blood pressure, and you can do that by drinking a lot, and sometimes you need to take some medications to help with that too. And Miralax can be a very helpful aid for constipation that is not uncommon in Lewy body disease. And if there is any Parkinsonism, the tremor, the rigidity, then we can use physical therapy first and foremost, and then some medications that are directly that will directly help with the tremor. All right, so there's a couple questions here. Can the REM sleep disturbance cause nightmares? It's more like you have a regular dream, but you're just kind of acting out that dream. So it's not necessarily nightmares. But drugs for dementia, so Aricept, not uncommonly, and some of these other medications in the same class, if you take them just before going to bed, people describe vivid dreams. And again, it's not that they're really nightmares per se, but people say, it was just, I just remember it. I remember all of my dream. And so people describe them as vivid. And if that's the case and you're bothered by it, you can just take it in the morning. Can you please comment on alcohol-based dementia? Right. So this is a condition that, typically after many years of heavy drinking, but it can be shorter than that. And one of the primary features in this is the confabulation, or the, telling stories. And it's often due to vitamin deficiencies. It's linked very closely to a deficiency, because when you drink a lot of your calories come from alcohol, and you have a tendency to eat less food, and you may lose out on some of these vitamins like thiamine, and you end up with this memory disorder called Korsakoff syndrome, in which case you have a lot of this confabulation. I think of ADHD as an executive functioning disorder. Is there any connection to Lewy body? Not that we know of. And ADHD primarily affects attention, while Lewy body, it's a component of the disease. We rarely, stimulants that are used often to treat ADHD do not help as much or any in Lewy body disease. So we think of them as kind of separate disorders. Memantine, Namenda. So there have been trials of memantine in Lewy body disease, and it's not effective. There's a lot of hype over memantine or Namenda, even in Alzheimer's disease, and in large part, it hasn't panned out. And I used to see it prescribed very often as first-line therapy. And now really we know the data just showed it helps a little bit, but only in combination with Aricept. So I don't prescribe it as much anymore. Can you please share your experience with dementia and epilepsy? Yes, I would be happy to. Can dementia lead to new onset seizures or a status epilepticus, which is nonstop seizures in the elderly? And does having history of epilepsy or frequent seizures lead to earlier onset incidence of dementia? Right. So there is a fascinating body of literature that connects seizures and Alzheimer's disease. It is a very open question right now. And some of this comes from the study of Alzheimer's disease, right? So scientists like to be able to study Alzheimer's disease. It's hard to do it in people because, well, people have a lot of things going on, right? And it's hard to make manipulations. So if you make a mouse that has Alzheimer's disease, they have memory problems as far as we can tell by doing different tests. And if you look by putting an electrode into the brain of a mice, they have a ton of seizures, the Alzheimer's disease mouse. They're seizing all the time. And as a matter of fact, some seizure medications can prevent those seizures and actually improve the memory of mice. It's really exciting when that came out. And so people started to look a little harder. And it turns out people with Alzheimer's disease have a much higher risk of seizure. And people with seizure over time have a higher risk of developing Alzheimer's. Now, there are, in that big diagram I showed you with all those 120 things, there are very active trials that look at some of the seizure medications in people with Alzheimer's. The thing is, with a mouse, you can stick an electrode in its brain, you can measure those seizures. We can't do that in a person because nobody wants a piece of metal in their brain. You can use an EEG, which are these little wires all over the head. And those are really good for picking up abnormal electrical activity in about a millimeter of the surface of your brain. But our brain is not that thin, right? It's thick. So we don't know what's going on in the brain in a person. It's very complicated, but really, I think, exciting stuff. And hopefully we'll see some data out of those studies soon. Okay, what about medical marijuana? This is a question that comes up very often, and it's hard to give you a good answer. And part of the issue is you hear stories or even read studies about really great outcomes with medical marijuana. And then you also read the opposite. And part of this is because it's not regulated, right? So if you or anybody else goes out and tries to get some marijuana or even cannabinoids, right, CBDs, and then you go a week later, you're going to get something different, right? So the concentration, the purity, even the make of the plant and where it was grown, all differ. And so if you're trying to study this, it's nearly impossible because it's not standardized, and we don't know what ingredients, what amount, and from where are helpful or not helpful. So a lot of anecdotes, not a lot of dependable studies right now. And I think it's a big open area that needs more reliable studies on a regulated substance. Does Ritalin have any effect on Alzheimer's? No, not that we know of. So the stimulants, that are based on amphetamine, it definitely makes people feel better. I can tell you that. But in terms of improvements in memory, it doesn't seem to change things. What is the proportion between sporadic and so I think how common is sporadic versus inherited disease? So in dementia, we or Alzheimer's, right, the most common one, we typically say about 10% or less is inherited in families. And the rest, 90%, is what we call sporadic, meaning it happens regardless of whether it is in the family or not. But it's not that simple. So it turns out if somebody has memory problems before age 60 or 65, much more common to run in the family and to have a genetic mutation that we can identify than if it occurs in the 70s or 80s. And if it does in the 70s or 80s, we say that generally, most often sporadic, just occurs spontaneously. Frontotemporal dementia, which I hope we'll have a chance to talk about, is different in that 4 out of 10 people have a very strong family history. And so there's a bigger genetic component to frontotemporal dementia than other conditions like Alzheimer's or Lewy body. Is there a correlation between any of these forms of dementia and migraine? Migraine, there is a relationship between migraine headaches and vascular disease. So very often true migraine headaches with aura, where you see the flashing lights or even anything else, there's a higher risk of developing stroke, and with that, higher risk of developing dementia. So there is a connection there, but not as much, not that I know of, with Alzheimer's or Lewy body or Parkinson's or frontotemporal dementia. I was diagnosed with ADHD and helped with Ritalin. I stopped taking the drug. Oh, that one disappeared. I am anticipating that the question was about whether or not stopping taking the drug would affect your risk of developing Alzheimer's disease, and I would say no. I do not think long-term use of Ritalin or any other medication for ADHD should affect your risk of developing dementia. All right, so I am going to breeze through this part right now. I really just wanted to highlight again some of the exciting stuff coming out, well, I hope will come out, of the science in Lewy body dementia, where some treatments are being tried to really block the formation of these Lewy bodies. And they start with immunotherapy, which is vaccines. You can vaccinate against things like COVID, but you can also vaccinate against things like Lewy bodies. And then drugs that are meant to do the same thing. And I'm not going to go into any detail here, but I think that there's some amazing work going on, and I am very hopeful that the same advances we're seeing in cancer right now with these new drugs that target different aspects of disease. I think that every year we see at least 1 or 2 new drugs come out in cancer. We're going to start to see for these disorders of memory. We're about 20 years behind cancer, but catching up. There's a lot. All right, so last one, and in the remaining time, I want to talk about Connie. She's 66, right? So a lot younger than these other people that we've talked about so far. And she's confused, right? So she's having some forgetfulness. She forgot to pick up her grandson. She got lost while driving, but she's also really quiet. She doesn't talk as much. She doesn't seem to understand what you're saying all the time. And she's got this weird thing with donuts. Whenever she sees donuts, she's got to eat it. It's the seafood diet. And she's actually gained a lot of weight because of it. And that's very unlike her. So this is a reference to frontotemporal dementia. And this is a really hard one, right? Because it can be so different. The presentation, people with this condition can have many different sort of presentations, right? So we talk about behavioral changes. The most common is something we call apathy. And apathy is really just an extreme form of withdrawal. The things that you or your family members or your friends like to do, just don't want to do them anymore. It's like being a teenager times 40, right? So you just kind of sit there. Disinhibition, you may actually, these people may actually do things that they wouldn't normally do. Sometimes it could be aggressive behavior. Sometimes it can be inappropriate behavior, using words or phrases or reaching out and inappropriate acts. Many married couples say, they would say, my wife or my husband, they just don't seem to care about me anymore. Like no emotion whatsoever. I know about one man who developed an obsession for glass mugs. So he actually lost his job because he would spend most of his day going from yard sale to yard sale looking for glass mugs. Eating disorder, as we talked about. Language problems, they can either have a hard time understanding you or a hard time making themselves understood. And then there can be these very characteristic problems with moving. Either that, the kind of tremor we talked about, falls, or something that looks identical to Lou Gehrig's disease or ALS, where they become weak, their muscles shrink, and they may have problems breathing, eating, or talking. This is what it looks like, and this is one reason why frontotemporal dementia makes a little bit more sense to me, because it involves the front of the brain and involves the part of the brain next to your temples, or the temporal lobes, and you can see that on MRI. There's some shrinkage here with the red arrow of the front part of the brain, and for people who aren't used to looking at MRI, so this is the front. This is like a section through the middle of your head. It's called a sagittal section. On this one, it's kind of a section like this. So this is the front of your head here, and this is the back, and this is the right ear and the left ear, because radiologists really enjoy confusing people, so they flip everything around. And you can see some shrinkage in these parts of the brain. And you can see that on these views too, that are kind of a slice up and down, or called a coronal section, where you can see more of that shrinkage. So MRI is good, but very often MRI, it tells you the shape of the brain, right? Areas that have shrunken. But it can be a very late finding. And you can have people who have a ton of symptoms, a ton of problems, and their MRI looks fine. So try to think about things that are better than MRI. And one of these is something called a PET scan. And I wouldn't say better or worse, actually, but it's different. So instead of looking at the structure, the shape of the brain, a PET scan, at least the most common PET scan, measures the activity of the brain. So your brain loves sugar. It functions on sugar or glucose. And this PET scan is called an FDG PET. It's the one we think about most often. You give a form of glucose that we can see on a scanner. And so we can look at different parts of the brain and how much sugar they use, and say how active that part of the brain is based on how much sugar it's eating. And it can be very helpful in distinguishing FTD from other conditions. And this is approved by the FDA. It's approved by Medicare. And we used to use it more often than we do now, because some insurance companies, particularly in Michigan, have stopped covering it as a policy decision for diagnosis or differential diagnosis of dementia. So it's become more challenging, I would say, in the past few years. All right, so this is an example of what a PET scan looks like. Normal person, it lights up because your brain is very active and it's using a lot of sugar. And in somebody with Alzheimer's disease, for instance, there's less lighting up. But it's really the pattern of that change in the activity that we can use to diagnose the disorder. So this, is, for instance, is a PET scan of somebody who has FTD. And you can see, based on the brightly colored purple areas here, that the front parts of the brain and the temporal lobes over here on the side are those that are primarily affected based on the scan. And so that, again, can be very helpful for us if we're trying to diagnose or distinguish it from other conditions. So I mentioned that we now, at least in Alzheimer's disease, have the ability to look at these proteins that build up in the brain without having to take the brain out. And that is very important, right? I don't think I need to emphasize how important it is to be able to look and see without having to do an autopsy. And so now we've adapted that PET technology for looking at amyloid, and it's been really transformative for Alzheimer's disease, only on the research basis. But as a matter of fact, just recently, amyloid PET was approved by the FDA. It's not yet covered under insurance, and so scans will cost in the thousands of dollars now, but we really, we're pushing, and there are studies right now that show that using this in clinical practice can save money, and so insurance companies hopefully will get on board. So this is a normal person that has an amyloid PET, and this is somebody who has Alzheimer's disease, and now it's the opposite, right? Because we're looking for the presence of this bad protein, and we can see a lot more. Even in people who have what we call mild cognitive impairment. And so this is where, you may be a little forgetful, but it's not really interfering with anything you want to do. You can write stuff down and you can sort of compensate. Sometimes, not all the time, but sometimes we can see the brain's lighting up, and that is an indication that there's a higher risk for Alzheimer's in the future. So what about FTD? Well, there is some PET technology that can be applied to FTD, but it's nowhere near usable yet. I mean, I don't want to say near. It's not quite as universally effective and usable as amyloid PET. So what do we do for FTD if we want to diagnose this condition? There are tests that are coming out again on the research side where you can tell if somebody has a dementia like FTD by getting spinal fluid, right, through a spinal tap, which is not a big procedure. It's often done in the office in a very safe fashion. And you can see here I've outlined in red that people with FTD will often have much higher levels of this protein. It's called neurofilament light, or easy to remember, I think, NFL, in their spinal fluid. So this can be very helpful. And as a matter of fact, it's not just in the spinal fluid. So it turns out that most of these same people will have elevated levels of NFL in the blood. So this raises the possibility, could there be a blood test for FTD? I think many people have heard about probably, I think it was earlier this summer, that there's some really compelling and exciting data from people with Alzheimer's that there may be a blood test for this tau protein in the tangles that we may be able to use in the future for helping to diagnose Alzheimer's. And this, raises the possibility that perhaps in the near future, we'd have a test for frontotemporal dementia. And I see this question from Megan about fasting and dementia, and I will answer that. So it turns out, I don't have to go into the data very much, but not only can NFL, this blood test, help us determine if somebody has a disease or not, it can also tell us how quickly things will move in the future. So if you have a low level of NFL, things progress more slowly than if you have a high level of NFL. So this is early days still, but there's a possibility that not only we can help with diagnosis, but also prognosis. All right, so I mentioned the genetics of FTD, more common, or at least a higher genetic component, higher family history than what we see in Alzheimer's disease. 4 out of 10 people. There are some very characteristic genes, 3 of them that we look for most often. And you may see your doctor or somebody else look for if, in fact, there's more than one person in your family. But that raises the question, right? If FTD is so different and heterogeneous, how can you tell if there's a family history? I mean, we essentially have to ask if there's anybody who has obsessive compulsive disorder or social withdrawal, or and it can be somewhat of a mess, and it helps to talk to a genetic counselor. So what about therapy? What do we do? So there are medications for depression and anxiety, these behavioral problems that can appear in FTD, same ones that we use to in psychiatry, actually. And I'm a firm believer, actually, in that neurology and psychiatry are just kind of 2 sides of the same coin. So if there are psychotic symptoms, which, again, delusions and hallucinations, these don't respond to Aricept like in Lewy body, and so often behavioral changes, and sometimes we have to use antipsychotics if they're very disruptive. And we try to avoid it at all costs if we can. Language problems, speech and language therapy can sometimes be helpful. There's cognitive impairment. There's nothing effective that we know of for helping with memory in FTD. Lots of very active research, though. And the motor symptoms, if there's ALS, then we usually have somebody seen in the ALS clinic. If there's Parkinson's, then we'll treat it the same way that we treat Parkinson's disease. But as you can see from this, all the treatments are based on the symptoms. So there's nothing that gets at the heart of the disease itself. And we are lacking that in FTD. These are some of the, I think, very exciting treatments that are being tested right now. Some of these are antibodies, right? So they're kind of vaccines. This is what we call passive vaccination. It moves fast. This particular part of biology and treatment can be tested very quickly. And in the in the laboratory with these mice running around, these treatments actually work pretty well. So we'll see what happens in people, because people are not mice. All right. And so I just want to sort of end with this, saying that, Alzheimer's may be one of the most common things that we see, but there are many other conditions to consider, and they are treated very differently. And so it's very important to recognize them. And so I'll end there and open with questions. I'm gonna answer this question from Megan. Is there any studies indicating correlation between fasting and dementia? So there are some pretty interesting studies looking at this intermittent fasting and dementia. And actually the sort of switch in your metabolism is something called ketone bodies. And there's some evidence that intermittent fasting can actually help prevent the progression and maybe even improve memory in some people. It's not very well controlled studies right now, but these ketone bodies in many other conditions can be associated with an improvement in memory and in outcomes. So it is an area of active research, but you can only, you got to do it in people, and studying diet in people is really hard. So it's an active area. Is there any overlap between epilepsy, multiple sclerosis, and FTD? There's less. So, well, multiple sclerosis and FTD, they have a big component of the immune system. And that a lot of the medications used to treat multiple sclerosis are those that target the immune system. And it turns out that in FTD, there's this very interesting connection with autoimmune disease. So those treatments, many of those treatments are being tested in FTD, in particular, some of the inherited forms of FTD that have a lot of inflammation, but you have to do them early. And so you have to figure out if somebody's at risk for FTD and test those therapies out. So I think there is a connection. What that is right now is pretty unclear. And epilepsy, less of a connection than, say with Alzheimer's disease. Is it possible to find a significant accumulation of amyloid in people without dementia? Yeah, great question. So when this amyloid PET technology, this ability to see amyloid in the brain, when it first came out, they started scanning as many people as they could find, right? Including controls and people with Alzheimer's. And it turns out that 1 in 5 people out there walking on the street has a bunch of amyloid in the brain. And at first, really confused by that, but it turns out that those people have a higher risk of developing Alzheimer's in the next 5 to 10 years, sometimes 15 years. So it's an important indicator, but we can't go out and scan everybody. All right, Matt, hey, how's it going? Also curious about FDG PET, if metabolic system is switched, say to using ketones through nutritional ketosis, if there's some strong anecdotes for using this strategy in PD and dementia. So there are definitely anecdotes for using ketone bodies. And actually we tried studying this in the lab too. But it's hard. And do we have a good PET tracer for ketone bodies? I don't think so, but you could see a drop in glucose utilization, right? You might get pretty scared. So it's a good question. Please explain sugar in the brain again. Are you saying a lot of sugar in the diet is good? No, I am not. I'm just saying that the cells in your brain use sugar as a source of energy, and so we can give a kind of sugar that we can see by scanning, and that allows us to see how much sugar is how much energy, how active a particular part of the brain is compared to another part. So it's just a way for us to monitor brain activity. Okay, and I think I made it through the questions. Right, and Danielle, I know you have a couple slides here at the end.
Yes. So thank you so much. That was great. And thank you again, everyone, for all of your questions. We have 2 upcoming speaker series events in January and February. So stay tuned for the promotions and more information on those. You can go to the next one.
Oh.
It's okay. And if you want to stay in the loop and, keep up with what we have going on at the center, then please subscribe to our e-newsletter. And then once you fill out the evaluation, you also have the opportunity to leave your information to subscribe that way and find out what's going on with what we're doing. So, again, thank you all so much for coming. And thank you, Dr. Barmata. And have a great day, everybody.
You're welcome. Take
All
care,
right.
everyone.